So, Dr. Udoka, let's start on this conversation on coronavirus and the readiness. You're part of the task force.
Yes.
Yeah, that is charged with making sure that we are ready as a country. Are we ready as a country?
As a country, so far we are ready. Actually, we have instituted isolation facilities at the national level in Kenyatta National Hospital, Bagathi, and Kenyatta University Teaching and Referral Hospital. We also have isolation facilities in at least 21 of the counties, and the other counties are speedily coming on board to institute and put in place isolation facilities. Yeah.
So in total, you think how many people can we take in, bed capacity?
In total, at the national level, we can be able to take care of about 100 people. Actually, 200 because Kenyatta National Hospital, Bagathi, and Aga Khan can take care of about 100, and Kenyatta University Teaching and Referral Hospital can take an extra 100 people.
So we're talking about 200.
200 at the national level.
And yet we know how aggressive the virus is. When it lands here, it infects hundreds at the same time.
That is correct, enough? But one thing we should be comfortable about is about 90% of the cases are mild. Only about 10 to 15% progress to severe, requiring hospitalization.
Yes. All right, Dr. Oluga, are we ready? Do you have confidence in our system to handle it the moment it lands here, when it lands here, according to Mutai?
Well, I think I have to say that the ministry has taken some steps. A few weeks ago, 2 weeks ago actually, we were talking no isolation facility. We were talking no preparedness in terms of training. So on two fronts, in terms of the isolation facility and in terms of training, I know a number of health workers who now have been trained. Of course, not 1,000 as they are saying, but it's still a very good step in the right direction. I know at least almost 90 doctors and a number of nurses, I think almost 200 or so that have been trained.
Is that enough?
No, that is not enough. Nurses? That is not enough. In fact, that's where I'm going to go to. So I think it's good that they have taken positive steps. The isolation facilities are there. The health workers have been trained. I think the most important thing right now that needs to be done beyond that, which I really commend the ministry for doing, and I think the new CS, Mutai Kagwe, needs to get the credit for having taken those measures quite quickly. But beyond that, there are two other things that are very important. One is that we need to build confidence in all the health workers, because 200 are not enough. And when we have an outbreak, it will not be any of those 200. It will be the one that you did not train. That is the one that will see the first case. So the training needs to be for all health workers, not just for the 200. And beyond the training is to build their confidence, and not just in the public facilities. As we have seen, coronavirus, it's spread more by people who are traveling and all that. So some of these people go also to the private facilities, sometimes even just the private clinics of a single doctor or a single nurse. So that awareness, and most importantly, confidence among all health workers to handle coronavirus is very important, and it has not been done. Number two is the public education. I think that generally there's been a lot of media effort, but with that media effort also comes a lot of misinformation. So there needs to be a concerted, consistent, and constant updates from the Ministry of Health on specifically what the public must do in terms of crowding facilities, in terms of cinemas, in terms of churches, in terms of sanitation. So I think those two things are yet to be done properly. And so I would say that we are not prepared. I don't think that we want the virus here, because our practices as Africans, and also the other thing that I keep saying is that our healthcare system is not as strong as that of China or Italy. You can see the way Italy is grappling with this. Italy's healthcare system is pretty strong. It's not the best in Europe, but it's pretty strong. So our healthcare systems in the whole of Africa are very bad. So we don't want it here. And I saw there's already a case in Congo DRC. So when it comes to Africa and when it comes to Kenya, we may just have a disaster. I think we are better off not having it, because if we cannot handle pregnant women who we lack blood, I don't think we even want to talk about the issue of corona. I don't think that also that the issue about 90% of cases are mild, that we need to bank on that, because it also depends on the healthcare delivery system, so the support system. So even just issues of hydration, issues of ICU support are very different. So the way a disease reacts in a certain delivery system is not the same way it will react with us here. So I think we do not know whether those 90% of cases are mild as it is said. Of course, there is also a bit of a pinch of salt with the data that is, I can say that because the WHO director traveled all the way to China to try and urge China to be a bit more transparent. And I think China was initially, they're a repressive state, so they were arresting healthcare workers who are giving information. So there's also a bit of pinch of salt from the data that was coming from China. You can see the aggression of the coronavirus in Iran and in Italy. So we may have room to doubt, and I think the scientists will tell us eventually when they do another survey whether the numbers and the aggression that was reported in China is real or not.
Dr. Mureithi, what are you learning about the virus that we need to know?
So, first of all, the coronaviruses, probably need to debunk them a bit. They have been there for quite a long time. The coronaviruses as a big family of viruses. It causes mild infections in that family, from common cold to more severe infections that we've seen in the last decade, such as SARS, that is severe acute respiratory syndrome, and MERS, that was reported in 2012 in Saudi Arabia, Middle East respiratory syndrome, and now this novel coronavirus that was described in December 2019 that we've not seen before, but belongs to that big family of viruses. Yes. So what we are learning from it, first of all, it's an RNA virus that derives its name from how it looks like. It has like a crown-like structure, spikes, that gives it kind of a crown. So that's why we are calling it a coronavirus, a Latin name. And it's enveloped, which for us as scientists is very important to be able to debunk all these structures, because they will inform how we'll make the drug, how we'll make the vaccine, and also already it's informed us that simple measures such as soap and that enveloped lipid layer that covers the virus, it's able to disintegrate this virus. That's what you're saying. Simply soap and water.
Yeah, okay. Here's the thing, Dr. Marianne.
Yes.
When I was doing my reading around the coronavirus, it's a virus that they say sort of stemmed from bats. And Kenyans, as we know, we are meat-eating people, and this is in terms of our lifestyle. You take a look at where most of the homes that are being built in terms of real estate, you will find it within either a swampy area or a forestry area. Just talk to us about how our lifestyle and what that does to a virus like this, how that maximizes it.
So maybe we can start with the Chinese situation, where they first described these viruses or this infection from that wet market in Wuhan, where they had all these type of animals. In fact, I was looking at the menu in December. They have of what was on sale during that period. They had everything from bats to bears to name it, it was there. And a wet market is where they're slaughtering, there are live animals, there are people buying these things. So there was that interactions of animal to animal and then to humans. So what we are thinking, it's through that interactions. The hypothesis right now was the bats, but there's this hypothesis, there's also an intermediary species that then led this virus to jump into humans. So in terms of our practices here, I don't think we really consume wild animals per se, but in an African setting, let's say in the Congo and other areas, yes, they do interact with these animals, they eat. But I also have to emphasize within our setting, we have been, I think, on surveillance mode for quite a long time because of Ebola, Lassa fevers. So I want to say the systems were somehow in place to detect these other emerging viruses. I was reading a report in Nigeria where, in fact, they were surveilling for things such as Lassa fever, which is another type of an emerging virus.
Right.
So I want to say the systems were in place to do this surveillance, to detect them. It's just that now we need to build this system, make sure that we are aware of or be vigilant, educate, as Dr. Luga has said, and make sure that we are ready. Yeah.
Okay, here is the thing. Speaking about surveillance, let me take us back all the way to 2006 when we had the H1N1, which was quite a star. That one came from Egypt. Now, the fact that the National Influenza Hub was established back in 2006 to keep an eye on the H1N1 outbreak, then over the years, we didn't report any cases. So those facilities have been run down. Government forgot about them. There was no funding towards those labs, and there were 26 labs. Here's the thing, Dr. Philip, we have found ourselves a few years later, but now staying at coronavirus. We had also Ebola scare a few years ago.
Actually, I would just want to correct some statements which have come from the panel.
All right.
In 2007, 2008, we had the H5N1 pandemic scare, which actually crippled most of the poultry industry in Southeast Asia. It came as far as Egypt, where it has become endemic. Since that time, the country has been preparing for these pandemics. Exactly. And that's why we are put on board and instituted the National Influenza Center, where we can be able actually to diagnose these problems. Thanks to that scare in 2009, 2008, that the country has actually built capacity. And it's from that time, the country started doing surveillance for influenza and other emerging respiratory pathogens. We had 12 sites across the country, which we scaled down to 6. Now we have central surveillance sites in Kakamega, in Marsabit, in Nairobi, in Nyeri, Nakuru, Mombasa at the coast. And from those sites, we have been able to detect other viruses. In 2009, we had the H1N1 scare, the pandemic which came, and initially it was referred as the swine flu.
Yes.
Then it became the H1N1 09 pandemic strain, which actually started in Mexico, not in Egypt, Mexico, crossed to United States, crossed to Europe, and by July of 2009, it was in Kisumu, where we detected, and we promptly detected that thanks to the systems which we put in place to do surveillance for respiratory pathogen. Thus, even this one, which is causing the scare across the globe, we are ready to detect it wherever it is reported.
Dr. Mudoka, is there a chance that someone can beat the system? If I'm having a bit of a fever, I take some repressants, and then when I pass through your machines that are trying to detect me, I'm clean.
You see, the incubating period for COVID-19 is about 5 to 6 days. So
it's not even
if
14
you are
days.
infected and you are within the first 2-3 days, you can pass through the system because you have not developed signs and symptoms. So there's a possibility of getting the infection within the country, and you are detected 5, 6, 7, even 10 days later.
So then how would you know? Because if I pass through and I have no signs, it means you will not be tracking me.
Actually, that is the same thing. That is the same thing which happened in 2009. Those British students which actually were first detected to have H1N1 passed through our airport, and 5 days down the line, we got the reports of a cluster of influenza-like illness in Kisumu. Then we went and we isolated these students, we tested, and we found the H1N1. The same, well, for any case which passes through the airport, we may not be able to detect at that time. But our health care workers on the ground, we're in the process of training them. We always send materials for them to have high index of suspicion. If you get a case of a upper respiratory tract infection, and this person has got history of travel to any of the affected countries like Italy, Korea, Europe, China, then please undertake secondary screening, whereby you need to put on gloves, a surgical mask, and protective gown, and interrogate whether this person may have passed through any of the countries with these infections have been reported. If they have, and the persons have the upper respiratory tract infection, then you take the oropharyngeal swabs and the serum samples, and you swiftly ship them to the National Public Health Labs at the NIC, where they will be tested, and within 24 hours you'll get your results.
All right, here's the thing, Dr. Oluga, we have 100 Kenyans stuck in China. According to Foreign Affairs PS Kamau Macharia says that our students, I quote, are safe where they are. since China is ensuring their safety, but then the government later on went to disperse about 1.3 million for the students and their supplies. And according to the letter that they sent to Foreign Affairs, it was the issue of psychological torture, but also the need of supplies. How the government has handled the 100 Kenyans in China, how would you grade that? And is it actually wise for the students to stay in China under the Chinese government? It's safer for them? Or?
So, yeah, that issue is a bit very delicate because one, we really empathize with those Kenyans who are stuck in China. And now from yesterday, I also see in Italy. And this may be anywhere else because now we have the 2 epicenters in Italy and then in China. But who knows, maybe in the next few days or weeks there will be another epicenter somewhere else, and there may be other Kenyans there. But I think the golden rule in control of outbreaks is to manage it where it is.
Exactly.
So looking at the science of managing outbreaks, you then also would understand why the government advises that the students or the Kenyans are better off managed there.
Right.
So I think 3 things. One is that if you are in China or you are in a place where there's an epidemic, don't leave, quarantine there. Number 2 is that if you are not there, like we are all in Kenya, don't go there. And number 3 is that if you have contact with the person that has either come from there or a person that has come from there or a person that you think is sick, then you need to self-quarantine and then use hotline numbers so that you are, I know that there's a lot of controversy about self-quarantine.
I was coming to that. What is that, Dr. How do you self-quarantine?
So, yeah, it is very difficult to monitor self-quarantine. Of course, we were very mad with the government when they allowed people from China to come in while leaving our students. And I think that put them in a very bad light, because how do you then allow other people to come while your own people are stuck there and you're not allowing them to come? But I think, so even with the WHO, there is no standard on this self-quarantine. So it is not a standard scientific practice. So that we have to clear from. Now, if I were to put on the science side, I think it's not a scientific practice that you can say. But in cases such as Ebola we saw, or in many outbreaks, instead of you going to a casualty or just taking yourself to hospital when you are sick, where there are many other people, you know, very sick people, and you're coughing there and you're waiting to see a doctor and you are interacting with other people, there's a chance of even spreading it in the hospital. So this is why it is advisable to self-quarantine, use a hotline, so that when people are coming for you at home, they're already having the measures, the protective measures. The health workers are having the protective measures. They will come and give you the protective measures, so that when you are going to hospital, the other people in hospital are safe. So this is the reason why self-quarantine is still a very practical advice, especially if you know that you have been in contact or you have that history of travel. So as much as there are no scientific ways of proving or the measures that we can say self-quarantine, but it's still an advice, because
does it lean more on risky or it being an effective method? Is it more of a risky method or an effective method? It's
effective in terms of when you self-quarantine and you think that now it is time for me to get checkup or to go to hospital, it protects the people in hospital. It protects the health workers, so it prevents spread of the disease.
Okay.
This is why it is very important.
All right.
Dr. Marianne, there's another question here that people have been wondering about second-hand clothing.
Yes.
Should we stop wearing them?
I've seen that going round on social media.
Yeah.
And first of all, let's again debunk this virus. How long can it survive? These clothes are coming from all over. It probably take days, weeks before they come here. And I'm sure in the manufacturing, the export-import industry, they have measures on how those clothes are packed and how they are finally sold to the common wananchi. But for the virus, from the studies that are coming through, they're saying that for it to survive for that long, it's without that warm human contact is probably not highly likely.
So it needs a host to survive.
It needs a host, but on these inanimate objects, like clothes, even this metal. I've seen even people talking about money or mail coming from all the way from China. There are studies that are showing on let's say on surfaces, it can take up to 9 days.
9 days?
9 days on surfaces. On clothes, probably a bit a shorter period of time, between 24 hours to 48 hours.
Okay.
So that's why we are emphasizing things such as disinfectants. Soap. Our disinfectant should have at least 70% of alcohol.
So then,
before, because of the duration of how long this virus can survive.
So should we even be handling cash then? Because I could give Zinzi money and she owes me some money. But still, she gives me money.
Yesterday there were images from the China's banks where they were actually literally spraying the money with disinfectant just because they're trying to stop any routes of transmission. Yes. So they have taken those measures in China. Maybe they'll cascade down to us. For now, I would really want to say we are safe. Mitumbas are safe.
Yeah.
They've survived for so long before they've reached here. The virus could have already disintegrated. But again, I really want to emphasize simply washing with soap and water.
But here's the thing.
Yes.
A county like Kwale County hasn't had taps running, flowing water for now a month. What do they do in such a scenario? Give me practical solutions that Kwale County residents can do, because they haven't had water for close to a month.
Quite a long time. Yes, I've seen that, and that's why now we need all arms of government, all arms of county government. Now we need to sit down and think. We are talking about running water, not just any type of water, running clean water. If our people do not have this running, cleaning water, what are other alternatives? So I'd really want to see people from the ministries, the county government, probably just ensuring that at least at this period of time, we can ensure that people have water. If not, what are other measures? Can we educate them to have alcohol wipes if they can afford, hand sanitizers if they can afford? We need to make sure they know the alternatives.
You're emphasizing running water because if it's water that is enclosed in a basin or something that an entire family is using to clean up, then it beats the purpose.
It beats the purpose, exactly.
All right.
Exactly.
And is there a chance, Dr. Mudoka, that there's post-infection resistance? Once you're infected with the virus and then you recover, is there a chance that you might be reinfected again, or that's it?
Just with any other diseases, when you get infected or exposed, your body develops defense mechanism. It develops antibodies. So it is unlikely that after you have recovered, you'll get reinfected by the same virus again, unless it has significantly mutated for it to be able to counter or attack your body as a new pathogen, as a new virus. But if it is existing virus, you get infected, you'll develop antibodies and you'll be able to cope.
But Dr. Philip, what is the task force doing? Because speaking about creating awareness, public awareness, what's the task force doing when it comes to this issue of discrimination? We've seen the viral video here in Kenya of the two Chinese who were sort of bullied in a low-income neighborhood. What is being done when it comes to not just awareness of the disease, but really create just the discriminatory part of it?
You see, when a system or when a community is devoid of the proper information about an issue, it tends to react in the similar manner the way you saw that discrimination. But what we're saying is everybody is at risk, and everybody who is coming into Kenya from any of the affected countries is also a risk to this country. So we are getting Europeans, Americans, even our Africans who have been to those countries doing business coming back to our country. So we should not actually stigmatize one race to say, because this guy has come from Korea, or this guy has come from Italy, or this guy has come from China, and he looks like a Chinese, or he looks like a Korean, he is a coronavirus. No. We should not discriminate. It is not possible to say, you as Marianne, you have come from China, you have the coronavirus. No. So what we are trying to emphasize is that we need, and we are educating our public that coronavirus does not just fly in the air, and coronavirus is like any other infection, like we have been getting common colds, as you have heard from my colleague, and coronaviruses have been with us. It's only that this new one has just crossed the species barrier, and the task force is what it's doing, basically educating the public. We have drawn elaborate education to public to include all the critical sectors of this country, of the economy of Kenya, the transport sector, the defense of this country, the security forces, the education sector, all the critical sector, even the energy sector, because we know preparedness in all these sectors is key to making sure when the problem gets to us, we are able to cope.
What is being done specifically about the transport system in Kenya? Because we know our matatu culture.
Now the system, what we're going to do, we are planning to go and bring the Matatu Owners Association together and the Taxi Owners Association to educate them on the measures they can take to try to avoid, the stigmatization or the infection from our tourists.
Has that started?
The plans are there. Mm-hmm. The plans are there. We have started in a small way, but we intend to spread it across the country.
I've seen what they're doing in South Korea has been very aggressive in their response. And one of the things they have done, first of all, they have tested nearly everyone that they were suspecting. So they have tested almost 200,000 people. If you had contact or travel. So like for the people that for us we are screening, South Korea has tested them within the window of 14 days. As he said, it takes about 5 days, but then there is that period of illness where you can still spread it for about 12 days. So yes, which is consistent with what you are saying, about 14 days. So that's what we have seen. Also, we've seen also in South Korea, they are even disinfecting public transport systems. You've seen the sprays that were being used. So some of them, they are spraying the train systems, the rails, even some taxis. So it is those are measures that we would like to see being taken. Of course, now you cannot start spraying. We have not identified cases yet, but I think we need to be prepared in such a manner. The other thing that Dr. Mutoka said is about reinfection. So there have been a few reports, I think 2 or 3, especially in China, of people who recovered and then
got reinfected
again. So just cases. I think scientifically it's still on. We are monitoring. I think the scientists will tell us. As you said, the coronavirus is just one of those severe acute respiratory viruses, and there's still a lot of monitoring to take place. But I think for me, what is very, very important is to, beyond the awareness, is really to talk to and to train healthcare workers. And I really want to urge the ministry that is really where the thing is, because even the panic that is there, even the discrimination that is there right now, is because the health workers did not have the correct information. And I saw some of our health workers have started doing something very good. For example, there are Chinese that are being discriminated. And in Nakuru, for example, there are some mines where the Chinese have come back, and we saw like Dr. Joy Mugambi and a few colleagues going to the mines to even train the Chinese themselves, to also train the community to destigmatize them, because they really feel discriminated. And this is very important because during the Ebola outbreak, there were Kenyans that were stuck in Asia. And because in Asia, they thought that Ebola is every African. So there were Kenyans that were really discriminated. So it is not just the Chinese. So even Africans have been discriminated before during the Ebola issue. So this is a very important point that people must know. And when you stigmatize people, they hide. So even if they had the disease,
and they were willing to come out.
The ward. So that means that there is the risk of spread. So people should not panic. We should just be prepared. But again, it comes to all health workers. And I think we need to work very closely with the ministry to make sure that all health workers are prepared and they are confident.